discussion on renal system. So in the last few days we had posted questions on uroradiology, and we'll try to discuss what these questions are and how to approach to the answer. So just I hope you're able to hear me clearly now. Just let me know if you're able to hear me and see me clearly. So yeah, so what we'll do is we'll start off with the first question here. So these were questions that were given in the DocTutorials integrated system-wise topics, and we had shared these questions on all the social media platforms, and even on the app on a regular basis these integrated questions are coming. And when you're solving them, right, so if you have any queries, we'll always be back and we'll try to solve those questions for you. And we'll start with the first question that was given there. Let me see if you all can also answer them, along with me. So did you try this question, guys? What is this question telling? Just look into this. This is a 2-year-old child with abdominal mass crossing midline and encasing the aorta and the inferior vena cava. So this is a mass in a 2-year-old child, and this abdominal mass is crossing the midline. It is encasing the vessels, the aorta and the inferior vena cava, and is showing fine calcifications and lytic bone metastasis. Lytic bone metastasis. What do you think this lesion could be? Any answers from your side? Please remember, this is a case of neuroblastoma. Neuroblastoma. So neuroblastoma is a lesion which is very common in a young child. Okay, so this is a lesion which is more common in young children. So if you look at the comparison between neuroblastoma and Wilms tumor, which are both abdominal masses, it is important to be able to differentiate these two lesions, right? How do we differentiate neuroblastoma from the Wilms tumor? Is neuroblastoma, you can see here on this contrast CT scan image, neuroblastoma is a lesion which will cross the midline. You can see it crossing the midline. This is a lesion which is encasing the vessels. It does not invade the vessel, it encases the vessel. It goes around the aorta, around the inferior vena cava. It encases the vessels but does not invade the vessels. And you can see on a CT scan, so the bones are white, so this is CT. And you can see the mass showing lot of calcifications. So if you have a lesion in a child, usually around the age group of 1 to 2 years, showing calcification, crossing the midline, encasing the vessels, right? Think of neuroblastoma. So this is a neuroblastoma. And please remember, when we have neuroblastoma, this usually shows metastasis to the bones. So neuroblastoma will show multiple lytic bone metastasis. It shows lytic bone metastasis. Bone metastasis. So it spreads to the bones. So if I have to tell you, if there is multiple punched out lytic lesions in the bone, multiple punched out lytic lesions, you heard of this term, multiple punched out lytic lesions in the bone. And if this is a elderly patient, right? Elderly patient, usually above 60 years. What is our answer? This is definitely what? Multiple myeloma, right? So this is multiple myeloma. But if the same wording is given with an infant or with a 1 to 2 year old child with abdominal mass, right? With abdominal mass, your better answer would be your neuroblastoma. This would be neuroblastoma. So please remember, neuroblastoma also shows multiple lytic metastasis, multiple lytic bone metastasis. So it has a bone spread. Now what do you think is this lesion? Where is this lesion arising from? Look at the CT scan. So you can see a lesion coming from the left kidney. So this is the right kidney. This is the liver for you, right? And this is the left kidney. And this is a lesion arising from the left kidney. This lesion is arising from the left kidney. And is it crossing the midline? Let me draw a line here. Is it crossing the midline? No, it is not crossing the midline. So this lesion which is not crossing the midline, which is limited to one side and which is arising from the kidney, it is seen to be arising from the kidney. You can see that claw-like area of the kidney, right? So there is a mass here and a kidney is forming a claw-like area. Okay, this is called as a claw sign. So this tells you that the lesion is arising within the kidney. So this lesion, which is only on one side of the midline, does not cross the midline, arises from the kidney. This is your Wilms tumor. Wilms tumor. And I'll give you a good table to differentiate these things. Please concentrate on this, table. How do you differentiate here? Neuroblastoma This is common in 1 to 2 years age group. Wilms tumor is between 3 to 4 years age group, usually between 3 to 4 years. You can remember N, neuroblastoma. N looks like 2 to you, right? So remember, neuroblastoma is around 2 years age group, right? 1 to 2 years age group, it is neuroblastoma. W looks like 3 to you, right? Wilms tumor. Wilms tumor is around 3 to 4 years. So I hope this will help you remember the age group. So around 1 to 2 years, it is neuroblastoma. Around 3 to 4 years, it is what? Wilms tumor. Neuroblastoma is usually a painful abdominal mass, whereas Wilms tumor is generally a painless abdominal mass. Calcifications. Remember, when I write calcification also, I write Ca plus 2, right? So same, you can remember N. You can remember N with this 2. So calcifications are also more common with what? Neuroblastoma. Whereas calcifications are less common with Wilms tumor. Calcification, if you're given a mass with calcification, think of neuroblastoma. And the neuroblastoma will encase the vessel. So I'll help you learn this also. Can you remember neuro like this? Neuroblastoma, it has E. So neuroblastoma encases the vessels. Whereas Wilms, WI, it has I in it. So it invades the vessels. So you can use these letters, right? So which encases the vessels, which goes around the aorta, around the vena cava, it is your neuroblastoma. Which invades the vessels, it is your Wilms tumor, right? Wilms tumor. And I told you, neuroblastoma shows spreads to the bone, right? Bone metastasis is seen with neuroblastoma. Whereas Wilms tumor, because it invades the vessels, right, it usually lands up producing pulmonary metastasis. So Wilms tumor is commonly, spread to the lungs. So Wilms tumor shows metastasis to the lungs, lung mets. Whereas neuroblastoma usually goes to the bones. And neuroblastoma, look at the name, it is very big compared to Wilms tumor, right? So neuroblastoma, it is crossing the midline, right? So neuroblastoma, right? It's a big name. So it crosses the midline. Wilms, right? Just small name. Wilms, it is only one side of the midline. So what I want you to understand is if you are comparing between neuroblastoma and Wilms tumor, remember these points that I have told you. What is the age group? With the letter N, you can remember 1 to 2 years age group. What is the age group for Wilms tumor, guys? Wilms tumor is around 3 to 4 years age group, right? 3 to 4 years age group. Neuroblastoma, this is showing calcifications. This generally shows calcifications. You can remember this word 2 again here, right? And looks like 2. And this usually less common, right? Less common. Calcifications are more common in case of neuroblastoma, less common in case of Wilms tumor. And with the letter E, remember, encases vessels. So it does not invade, it encases. So it lifts the aorta, it goes above and behind the aorta, elevates the vessels, but does not invade vessels. So this is neuroblastoma. Wilms tumor, you put the letter I, you remember, invades vessels. And which crosses midline? Which is a bigger name? This is a bigger name. So this crosses midline, right? Crosses midline. And your Wilms tumor does not cross midline. It stays one side, does not cross the midline. And what is the type of metastasis produced by neuroblastoma? Neuroblastoma produces bone metastasis, right? So bone mets are produced. Multiple punched out lytic lesion in a child in infant age group is what? Neuroblastoma. Whereas some Wilms tumor produces lung metastasis. It produces lung mets. So lung mets is Wilms tumor. Bone mets is what? Neuroblastoma. Bone mets is neuroblastoma. I hope you are clear with this differentiation, right? Let's move to the next one. So now look at this next question here. A 20-year-old male with loin pain, vomitings is suspected to have renal calculi. So loin pain, vomiting in a young male, right? So you're thinking of a renal calculi. Ultrasound was done and it shows hydronephrosis. So already ultrasound shows the hydronephrosis, but no calculi was detected on the ultrasound. The most sensitive modality for diagnosis of ureteric stone. What is the sensitive modality for diagnosis of ureteric stone? In this patients with acute renal colic. Please remember, the most sensitive investigation to look at ureteric calculi is a non-contrast CT, okay, non-contrast CT scan. So see, the ultrasound may just show hydronephrosis. It may not pick up calculi, especially when they are in the distal ureter. So the better investigation to look at ureteric calculi is a non-contrast CT. Now please remember, you do a non-contrast CT. If we give contrast and there is a calcification, and if I give contrast, the contrast would come into the ureter, and I would not be able to differentiate the calcification from the contrast. So the better investigation to look at calculi, right, ureteric calculi, is a non-contrast or a plain CT scan. Okay, plain CT scan. This is the next one. Now let us look at the other question that we discussed. A contrast enhanced CT scan image from a patient was evaluated, and the medical student is curious to identify what structure is the arrowhead pointing to. So there is an arrow given to you here, right, and they're asking you what is this structure. Is it a right renal artery, right renal vein, left renal artery, or left renal vein? By looking at the contrast CT, you can see that the bones are white and the contrast appears white, right? So this is a contrast enhanced CT scan. And this side is the right side in the CT scans, right? So this is the right kidney, this is the left kidney that you have here. Now he's asking you what is this structure marked by the arrow? What is the structure marked by the arrow? Let me trace them. This anterior vessel is going and opening into a structure here, and there is another vessel coming right towards the left kidney. And if I see below, I can see another vessel which is coming and opening into this contrast opacified area. So there are two vessels here. One is the renal artery and one is the renal vein. And we all know that the vena cava will lie towards the right side of the aorta, right? So this is the aorta. So this must be what? Inferior vena cava. This is the systemic abdominal aorta and the IVC. And once you understand the IVC and aorta, it is easy to understand which vessel it is draining into. So this vein that is coming towards the IVC, that must be your renal vein, the right renal vein. So this is your right renal vein. So first identify which is aorta, which is vena cava, and then you can identify the renal vein. This posterior vessel going towards the aorta, this is the right renal artery. So important to understand which is aorta, which is vena cava, then try to trace back the vessels to know which is, the renal vein and the renal artery. And you need to remember how the structures are arranged in the hilum of the kidney. Remember, in the hilum of the kidney, when you see the structures from anterior to posterior direction, what are the structures that we see? We see a renal vein, which is the most anterior structure. So in the hilum, the most anterior is the vein. Next is the artery, and next is the posteriorly is the pelvis. So from anterior to posterior, we have vein, artery, and the renal pelvis. The most posterior would be the renal pelvis. So even if you have remembered this, right, you could go back to the image and see that the structure that is coming anteriorly, is your right renal vein. Posterior to that would be your renal artery. So remember, in the renal hilum, the VAP arrangement, right, from anterior to posterior side, the vein will be the most anterior, right? Next will be the renal artery, next will be the pelvis. So that was the next question. Let's look at the next image. Now this was an interesting question, and I've seen many students commit an error on this. Let us discuss this clearly. Now let's look at the image. The first one, a 20-year-old female presents with recurrent urinary tract infection. Identify the condition based on the given intravenous pyelography image. So look at the intravenous pyelography image, and what do you think is the correct answer for this? Now, you have any answers for this? What do you think is this? Is it a pelvic kidney, horseshoe kidney, duplex kidney, or a crossed ectopic kidney? So if you look at the image carefully, you are seeing that in the right renal fossa, you see a kidney. But I am not seeing a kidney in the left renal fossa. But there is one more renal pelvis seen below it on the right side. And you are confused whether it is a duplex or a crossed ectopic. Pelvic, obviously it would be below the pelvic brim, right? The pelvic kidney would be below the pelvic brim. The most common site of ectopic kidney is the pelvic kidney, and it would be below the pelvic brim. Horseshoe kidney does not cross one side of the vertebra. Remember, horseshoe kidney, right? Both the kidneys are on either side of the vertebra, and they will be fusing in the midline across the vertebra like this, right? and you would see the shaking hand sign, right? When you see a IVP image of horseshoe kidney. So this is not a horseshoe kidney because both the kidneys have, come to one side of the vertebral column. In horseshoe kidney, the kidneys will be on either side of the vertebral column, and then they'll be fusing in the midline. The inferior poles of the horseshoe kidney will be fusing in the midline. Now, is it a duplex or is it a crossed? For a duplex kidney, you should see the normal kidney in the normal fossa. So in duplex kidney, the normal kidney is in normal fossa. Normal kidney will be present in normal renal fossa, right? And then there will be a duplication of one side. But here there is no normal kidney, okay? No normal kidney, right? And instead you are seeing two kidneys fused on the one side. So this, the better answer here is what? This is a crossed ectopic kidney, crossed fused ectopic kidney. Let me show you with the image, you'll understand it better. So basically, when you have a crossed fused ectopic, what is it crossed? It has crossed the vertebral column. So you don't see the normal kidney in the normal renal fossa. Instead, it has crossed the midline and fused with the other kidney. This is a crossed fused ectopic, and you can see the IVP image like this without any normal kidney in the normal renal fossa. That same kidney has actually crossed the vertebra. So it's a crossed fused ectopic, crossed fused ectopic. So don't confuse it with a duplication. I've given you one more image to help you, understand the crossed fused ectopic better. So here you can see again two kidneys on one side of the vertebral column. You don't see any kidney on the normal renal fossa. This is a crossed fused ectopic. Don't confuse it with duplication. Here also you can see on a axial CT scan image, both the kidneys are fused, right? So, and they're on either one side of the vertebra. So this is crossed fused ectopic, and a coronal image also showing you the crossed fused ectopic, right? So this is how we have the crossed fused ectopic. Horseshoe kidney will not be on, one side of the vertebra. Horseshoe kidney, they'll be on either side of the vertebra. Okay, they'll be fusing from either side of the vertebra. So that is how to differentiate whether it is a horseshoe kidney or is it a crossed fused ectopic. Horseshoe kidney, both the kidneys will be on either side of the vertebra. Only their inferior poles will be fusing. In crossed fused, they cross the vertebral column and fuse with each other. So they'll be on one side of the vertebra. I hope you are able to understand what is a horseshoe kidney and a crossed fused ectopic, and how we can differentiate it from a duplication system on the IVP images. Let us come to the next question now. Now, to make it more better, look at the similar question here. A 20-year-old female is being evaluated for recurrent urinary tract infections. Identify the condition based on the IVP image. So look at the image here. Here, again the IVP image, you can see the right kidney in the normal right renal fossa with the pelvic calcial system and the right ureter being normal. On the left side, I see there are two ureter, a superior ureter and an inferior ureter. So what do you think is this? Is it a crossed fused ectopic or a duplication? Because you can see the normal kidney in the normal renal fossa, right? This is not a crossed kidney. Instead, the left side, there is duplication. So this is duplication of the ureter. That is what I mean to differentiate crossed fused ectopic from a duplication system. Please look at the normal kidney. If you see the normal kidney in the normal renal fossa, the better answer is duplication. If you don't see the normal kidney in the normal renal fossa, the better answer is your crossed fused ectopic. Okay, so I hope this is clear. So this becomes duplication of the ureter. Next. Okay, guys, next one, try this question. A 70-year-old male smoker with hematuria is being evaluated. So it's an elderly patient, male smoker, and he is having hematuria. Identify the condition based on the IVP image. So look at the intravenous pyelography image. What do you think is this image showing you? Is it a pelvic kidney, crossed unfused ectopic, RCC, or a horseshoe kidney? So look at the IVP image. Look at the pelvic calcial system. Is it above the pelvic brim or below the pelvic brim? It is above the pelvic brim. So this is not a pelvic kidney. Pelvic kidney is the most common type of ectopic kidney, but the IVP image will show you the pelvic calcial system ending in the pelvis rather than above the pelvis. Okay, so the pelvic kidney, the ectopic kidney, the most common site of ectopic kidney is the pelvis, but you will see the pelvic calcial system ending at the pelvis. This is above the pelvis on the right side, right? It is above the pelvis. Crossed unfused ectopic, They have not crossed. The two kidneys are on either side of the vertebra. So there is not a crossed. So this is also not a crossed kidney. RCC or horseshoe kidney. In horseshoe kidney, how is the inferior calyx? They are medially oriented. Please understand, in a horseshoe kidney, what happens is when you have a horseshoe kidney, when you look at the pelvic calcium system, the inferior calyx will be more medially oriented like this. So you will have the inferior calyx more medially oriented, right? So the medially oriented inferior calyx, this in horseshoe kidney, this is called as shaking hand sign. This is your shaking hand sign. Shaking hand sign. But here I don't see the inferior calyx, shaking hands. They are laterally present only. Here the calyces, when I look at the IVP image, right, I am seeing all the calyces being laterally only. They are not medially oriented. So this is not even a horseshoe kidney. In horseshoe kidney, the inferior calyx would be medially oriented. So the out of exclusion, you can come to RCC. Out of exclusion only, you can come to the answer as RCC. Let us understand what exactly is happening here. So this IVP image is showing a very classic radiology sign. This sign is called as a drooping lily sign. So when you see the image like this, this is what is called as a drooping lily sign. Drooping lily sign. And drooping lily sign is seen in two important conditions, right? You see such kind of IVP images in two important conditions. First thing, D for D, you remember. Don't get confused with ectopic. Don't get confused with horseshoe kidney. First thing I want you to remember is drooping lily sign is seen with D for D. It is seen with duplication or duplex kidneys. Okay, duplex kidney. Right. So first thing is D for D. D for D. Drooping lily is seen with duplex kidney. But here we are only seeing one kidney. What happened to the other kidney? What happened to the other kidney? I see the left kidney normally in the left renal fossa. But here I am seeing only one thing, right? You see here I am only seeing one. But we are saying the drooping lily sign is seen in duplex kidney. So what happened to the other moiety? Basically, there is a non-functional upper moiety. So duplex kidney with non-functional upper moiety. So the upper moiety is not having any, functionality. So it is very damaged, right? So because of the obstruction or hydronephrosis or thinning of the parenchyma, it is not taking up contrast, not excreting the contrast anymore. So you have a non-functional upper moiety, So when you have a duplex kidney with non-functional upper moiety, the upper moiety or the upper kidney will not take up the contrast at all, will not excrete the contrast into the pelvic calcium system. So you will not have the upper kidney visible, and it will keep pushing the lower kidney downward, producing this drooping lily sign. So drooping lily sign is seen in duplex kidney with non-functional upper moiety. Let me show you an image. Look at here. So the upper kidney is the superior kidney is hydronephrotic, non-functional, right? Even though it is a duplex kidney, I only see one pelvic calcium system because the upper moiety is non-functional. Upper moiety is non-functional. It is compressing the lower moiety downward. So this is a duplex kidney with non-functional upper moiety. And this is what is called as your drooping lily sign. So please remember D for D. Drooping lily sign is seen in duplex kidney with non-functional upper moiety. And please remember, what is the most common site of origin of RCC? Most common site of RCC, right? It is from the upper pole, right? It is also from the upper pole of the kidney. So even when you have a mass cancer, a renal cell carcinoma, elderly, male, smoker, hematuria, all those clues were given, right? Even the history was sufficient, right, to answer it as RCC. Elderly, male, smoker, hematuria. And the mass which arises from the upper pole usually, right, it pushes the lower part of the leftover pelvic calcium system downward. And this will give you the appearance of a drooping lily. So drooping lily sign is seen with duplex kidney with non-functional upper moiety, also with RCC, renal cell carcinoma, which usually arises from the upper pole of the kidney. So please remember this drooping lily sign, Now here I want you to remember one important law. When you have duplex kidney, whenever we have a duplication system, we have an important law in duplex kidneys called as Vaquette-Meyer rule. Vaquette-Meyer rule. So I want you to remember this first thing. Where do you see this Vaquette-Meyer rule? And what is it all about? Weigert-Mayer rule is seen in duplex kidney. The first thing I want you to understand this rule is with duplex kidney or duplication system. Okay, duplication system. And what does this rule say? Remember the Weigert-Mayer rule as SIMO, S-I-M-O, SIMO. So try to memorize this. Okay, so the Weigert-Mayer rule is SIMO. What is SIMO? The superior pole moiety. So that means the ureter of the upper pole or the superior pole ureter. If you trace it, if I trace this down, it goes all the way more inferiorly and medially. So the superior ureter inserts infero-medially. The superior ureter inserts infero-medially. So it is an ectopic insertion. Okay, it's an ectopic insertion of the superior ureter that is happening and is prone to obstruction. And this obstruction is mainly in the form of ureterocele. You can see here the cobra head appearance or adder head appearance, right? Ureterocele. So please remember this SIMO first. If you remember SIMO, you can remember Weigert-Mayer rule. So where do you see this Weigert-Mayer rule? Weigert-Mayer rule is seen in duplex kidney. And what is this rule saying? It says that the ureter of the superior kidney, the ureter of the upper moiety or the superior kidney, as for superior ureter, it inserts infero-medially on the bladder. It goes much more inferior and much more medially on the bladder. It has an ectopic insertion and is prone to obstruction, mainly in the form of ureteroceles. And the opposite of it is also right. So if you look at lower ureter, it will be inserted. So lower ureter, so superior you can remember it as inferior, and infero-medial will become superolaterally. The lower ureter will insert superolaterally normally, the normal insertion. It's a normal orthotopic insertion. The superior ureter will have ectopic insertion. The lower ureter will insert normally on the superolateral side of the bladder. And this superior ureter was prone to obstruction. This will be prone to reflux. So once you remember SIMO, opposite of that is correct for lower ureter also. The lower ureter inserts normally on the superolateral side of the bladder and is more prone to reflux. The vesico-ureteric reflux in the duplication system is more common in the lower ureter. It's more common in the lower ureter. I hope you are clear with this, right? So this is about your Weigert-Mayer rule. Weigert-Mayer rule. Do remember SIMO, right? SIMO. And I hope you understood how a drooping lily sign is formed. Drooping lily sign, both duplex kidney and with a non-functional upper moiety, duplex kidney with non-functional upper moiety, and even RCC, because renal cell carcinomas commonly arise from the upper pole, pushing the pelvic cell system downward, giving the drooping lily sign. And in duplication system, don't forget the Weigert-Mayer rule, right? SIMO. Superior ureter is inserted ectopically, infero-medially on the bladder, more prone to obstructions, commonly as ureterocele. Whereas vesico-ureteric reflux is more common with the lower ureter. Lastly, the last question. Let's have a look at this question here. So there is a 40-year-old female with low IQ. So there is a female with a low IQ on anti-epileptic medications and on antiarrhythmic drugs with presence with constant abdominal pain. The CT scan abdomen of the patient is given. What is the likely diagnosis, or what does the CT scan suggest? So let us look at the CT scan images. So this is a coronal CT and this is an axial image given to you. And you are given a female who is having low IQ, epilepsy, arrhythmias, right? And the coronal and axial CT scan images are given. What is the likely diagnosis? Is it bilateral RCC, bilateral hydronephrosis, bilateral angiomyolipomas, or is it autosomal dominant polycystic kidney disease? Now try to understand what the image is showing you. If you look at the kidneys, right, in both the kidneys, right, these are the enlarged, bilaterally enlarged kidneys, right? These are the enlarged kidneys that you are seeing. And if you see the bilaterally enlarged kidneys, you look at the content inside the kidney and compare it with the subcutaneous fat. So surrounding subcutaneous fat and the appearance within the kidney appears similar. That means these hypodense areas within the kidneys which are resembling the subcutaneous fat are basically fat containing lesions in the kidney. So by looking at the subcutaneous fat, you know that what the hypodense areas within the kidney are also what? Fat. So such hypodense areas, bilaterally they are hypodense areas. That means there are fat containing areas. Please remember how fat appears on the radiology. This is very important, very basics to remember. Fat is radiolucent. That means it will appear black on X-rays, right? On the radiographs, it appears black. Fat is radiolucent. Fat is hypodense. That means it appears dark on CT scan, right? Fat appears hypodense. Fat is hyperechoic. Fat appears white on ultrasound. White. Lipoma is white on ultrasound. Fat is hyperintense. Both on T1 and T2 weighted imaging, fat will appear hyperintense. It will always white both on T1 as well as T2 weighted MRI. So fat is radiolucent. Fat is hypodense. CT and X-rays, CT also uses X-rays, so similar appearance. So fat is radiolucent on radiographs, hypodense on CT, hyperechoic on ultrasound, and hyperintense on MRI. So it is black on X-ray, black on CT, white on ultrasound, white on MRI. So this is a fat containing lesion in the kidney, which is resembling the subcutaneous fat. So these are your bilateral angiomyolipomas. The fat containing lesions in the kidneys, these are what? Bilateral angiomyolipomas. And if you look at the history, what is this suggest you? Where do you see this association of bilateral angiomyolipomas? Bilateral angiomyolipomas are commonly seen in patients with tuberous sclerosis, right? So tuberous sclerosis. And look at the question. What is it showing? It is showing that the patient is having epilepsy, low IQ, right? Low IQ. So epilepsy, low IQ, these are all part of your Vogt triad of tuberous sclerosis, right? So epilepsy, low IQ, angiofibromas, all of these are suggestive of what? Vogt triad. Remember the Vogt triad of tuberous sclerosis. Vogt triad of tuberous sclerosis. So epiloia, right? Epilepsy, low IQ, and angiofibromas or the adenoma sebaceum. You previously used to call it adenoma sebaceum. Now we call it as angiofibroma. And these patients of tuberous sclerosis are commonly associated with what? Bilateral angiomyolipomas. Bilateral angiomyolipomas. And why is the patient on antiarrhythmic drugs? Why do you think is the patient on antiarrhythmic drug? Any association of tuberous sclerosis with cardiac manifestations? Which cardiac manifestations is seen associated with tuberous sclerosis? Please remember, in the heart, these patients commonly have cardiac rhabdomyomas, okay, which could be a reason for their arrhythmias, cardiac rhabdomyomas. So these are your, features of tuberous sclerosis. So a lot of other things that you learn, right? Adenoma sebaceum, angiofibromas, bilateral angiomyolipoma, ash leaf macule, right? Ash leaf macules on tuberous sclerosis. There is, chagrin patch, SIGA, subependymal giant cell astrocytoma, subependymal calcifications, right? Along with LAM in the lungs, okay? Lymphatic dilatations in the lungs, lymphangioliomyomatosis in the lungs. So all of those things, right, are features of what? Tuberous sclerosis. So I hope you understood the clinical scenario and how to interpret it with the radiological image. So that is about tuberous sclerosis. So any fat containing lesion in the kidney, you are seeing a fat containing lesion in the kidney, which is similar to the subcutaneous fat. Look for angiomyolipoma. Strongly suspect angiomyolipoma, right? So that was the questions that we had shared in the social media on the DocTutorials social media platforms, and also on the app regularly. The integrated subject-wise tests are being posted. So try to solve them, and we'll come down with any of your queries regarding those questions, and we'll try to see that you're on track with your integrated preparation also. I hope you enjoyed the session. Thank you so much. Any queries you have, you can please ask me. Okay. All good, right?